It's very nice to see you and to see professors from India and Sri Lanka and our international friends. I mean, focusing on non-invasive technology in chronic liver disease, because as you all know, HK Medical is young and very novel company in China, and their machine, the FibroTouch one, is very simple and useful, applicable. I have two machines in my unit, and it's very useful for. It's very friendly for the operators, for nurses, and so it's will provide more and more data about the in the liver international in the liver disease. So and also I'm honored to introduce the first speaker, Professor Arjuna De Silva, and his topic is about the application of the TE in management of chronic liver disease. And so the questions and answers will following the topic. So please, Professor Arjuna De Silva, please.
Thank you, Christian, for that introduction, and I expect for organizing this seminar. The application value to transient elastography, or TE for short, in screening and management of NAFLD. So I'll first discuss a case which is common in primary care medicine. As a 35-year-old accountant who is a teetotaler and past history of diabetes mellitus, presented for a routine medical checkup, and his BMI was 32, diagnosed with ultrasound examination. His hepatitis B and C serology were negative. So how would you assess it? So hopefully after this lecture on outcomes as well, we'll be able to answer this question much better than at the moment. When we talk about NAFLD, it's a huge global problem. 25% prevalence. When you just think of that number, it is staggering. So we are truly in the middle of pandemic, and we are having an epidemic of NAFLD as well. So prevalences in Asia is about almost 32%, South Asia 34%, and Sri Lanka, one study done in an urban population. That I work in Ravan, where it's mainly urban, where it's about 32.6, and it's less in the rural population. If you take about 51% of the patients are obese, and about 22.5% have diabetes. So we all know that NAFLD is a spectrum. You have non-alcoholic fatty liver, so the diagnosis of NAFLD. So I won't go into the controversy of NAFLD and NAFLD. The new nomenclature coming. We need that for questions, but so we call it NAFLD. Steatosis more than 5% of hepatocytes. And NASH, of course, requires specific pathologic criteria, and exclusion of secondary causes and alcoholic liver disease, and obviously the associated metabolic risk factor. So NAFLD can go into HCC directly as well. It can go via NASH, and NASH itself can go into fibrosis, early fibrosis, F1, F2, F3, severe fibrosis, and F4, which is cirrhosis. And at any stage, it's important that, again, HCC, this can go into HCC. That is the really worrying thing we have. So that's important. So if you take the natural history of NAFLD, about 20 to 30% of NAFLD can go into NASH, and 20 to 30% of NASH can go into cirrhosis. And if you take NASH, about 5.2 per thousand can go into HCC. And the important thing here is that 40% of HCC is found in a non-cirrhotic liver and NAFLD patient. So it's very, very important to remember this fact. The scientists going to HCC in a patient, we don't know what to do there. Why do we need to screen NAFLD patients? There's a simple answer to that. The degree of fibrosis is considered the strongest predictive factor of correlating the progression of NAFLD with life-threatening complications. So fibrosis is the key to the problem. Why we need to screen? Because we need to find out who is going to get in fibrosis, so who is having fibrosis. So when you talk about screening NAFLD patients, there is a gold standard liver biopsy. I put that in inverted commas on purpose because though it's the gold standard, there are problems with the gold standard as well. The first thing is the gold standard is a very invasive test. And mortality as well. And in this day and age, that's almost unacceptable. So, it will give you only a core of the liver. It won't give you the entire liver. So, there are problems in the gold standard. However, most studies still insist on having liver biopsy as a standard. And even in drug trials, that is the norm. If you take non-invasive tests for fibrosis, we have FIB4, fibro tests, NFS, APRI, fibrometer, many of them. Then we have transient elastography and other ultrasound-based systems which with various force impulse of RFI, RP. We have MRI elastography. When you talk about measuring fat in the liver, then we have theater test, fatty liver index, and we have MRI proton density fraction. So these are all non-invasive tests to measure NAFLD fraction. If we talk about transient elastography, the two components in the modern machines, we measure the liver stiffness of fibrosis, which is liver stiffness measurement or LSM, and you measure the fat content, which is called controlled attenuation parameter or CAP. You are measuring actually two components in one shot. So what does transient elastography look like? So there are two machines here, FibroTouch on the right side and FibroScan left. So as you can see that the elasticity score is given in the brown color and the cap is given blue and it's given in white. So we'll discuss all these how to interpret these as well, but this is the What about the clinical applications of transient elastography in NAFLD? So if you take controlled attenuation parameter of CAP, you can diagnose fatty liver. You can screen for fatty liver in general population, especially type 2 diabetes and obesity, high risk people. You can monitor changes in liver fat, which needs more data. To take liver stiffness, estimate the severity of fibrosis we spoke about, and you can select patients for clinical trials. You can screen for liver fibrosis in general population who are high risk individuals. You can predict varices, sequence, carcinoma, liver related. can monitor your fibrosis again. You need more data on this. So, if you talk about liver stiffness measurement, let's say during vibrations of mild amplitude, low frequency, transmitted by transmitter, inducing an elastic shear wave that propagates through the underlying tissue. So, it ranges from 1.5 to 75. Examines the volume, obviously you can't see cells, but 100 times bigger than a liver biopsy. That's important. It is well validated with histology. There are so many studies which are just so briefly. And the value, this is another important point. The values are disease specific. Things the values on NAFLD are not the same, exactly the same as hepatitis C. Another important thing dependent on BMI. So, what are the cutoffs for fibrosis? And we will discuss it. There is a lot of evolving field. So, these are quoted from Edois, which is currently one of the largest studies done. Less than 5 kilopascal is normal, 8.2 is F2 fibrosis, 9.7 is F3, 13.6 above that is F4. What about quality of cholesterol? So actually, both machines that are used, they are very easy to operate, and because they actually tell you when you do a wrong measurement. But there are certain basic parameters, at least 10 valid measurements you have. You should have a success rate of more than 60%, valid measured by the number of attempts. Interquartile ratio of 0.3 or what we use mainly is IQR divided by median. It should be less than 30%. There is no really hard evidence for this, but this is what everyone who does fibrosis can accept at the moment and use. So here I don't expect to go through this, but this is showing you that how much studies are there on using fibrosis, liver fibrosis on biopsy as a gold standard, and comparing elasticity. So, the last one is about 400 odd patients. These are not huge amounts of patients, but there are significant amounts, and there are enough studies out there showing that there is a very good correlation between fibrosis and scope. What about problems with liver stiffness management? Obesity is a problem. If the BMI is more than 30%, the accuracy drops. So that you will need an Excel to a large probe. Hepatitis, so elevation of the liver times, more than 3 to 5 times, will definitely cause an increase in stiffness. So if there is a very acute hepatitis, then there is no point in doing fibrosis. Antibiotics cholecystitis is eating the blood flow. So generally they fast for about 4 hours before. If you have liver lesions, you can again thanks to your it's always better, almost mandatory to have a normal ultrasound before you go for fibrosis scan. You know exactly what's happening. So let's visit the guidelines and see how they look at non-invasive disease, and we decide that what we can use. So if you take the AASLD or American guideline, you have diagnosed steatosis on suspected with excluded alcohol and other things like hepatitis C. So you calculate the field score. So the field score is very easy, and you calculate with any smartphone can have it, and you just need a platelet count, AST, ALT, and the age. So even a rural hospital anywhere, also and I work in data, so we know community states. So you can do even a rural hospital anywhere you can calculate the FIB4 easy. So if the FIB4 is below 1.3, it's a low risk. So then you don't need to think about the liver, but there are other risk factors, cardiovascular, diabetes, all that. So you prefer that to primary or primary care and this that. If it is more than 1.3, then you are at a high intermediate risk and go for a blood pressure and do transient elastography. And if it's below H2 fibrosis, again, that follow up. If it is more than H3 or it's different, you can go for liver biopsy. This is what the ASALD says. That's exactly. So, a fairly rational approach. What about the ASG guidelines? So this is again staging. So they use two algorithms. So one is using biomarkers, the other is using transient investigation. So here again they will use the FIB4 NFS score. So here, so the magic number here is 1.3, easy to remember, and NFS 1.4. So if it is less than that, then you return to the primary care for like the measurements. If it is in between 1.3 and 2.67, then you proceed to another form of screening. And if it is more than that, then you will go ahead and go for a liver biopsy. If you follow the other arm, that is doing transient elastography. Again, we are here now, we are using a cutoff of 8 kilopascals. If it is below that, because another thing to remember is that transient elastography is useful for more excluding, more confirm. So then, if it's between 8 to 12, it's intermediate risk, and more than 12 is considered high risk from that part. These are the EASL guidelines. Again, patients with chronic liver disease, metabolic factors, you calculate the FIB4. So the FIB4, I think all people agree that that's the first thing to do because it's easily accessible and you can proceed with that. So FIB4 below 1.3, low risk, follow up, retest in 1 to 3 years, probably 1 year is better. If it is intermediate or more than 1.3, you do a transient elastography. It's less than 8, low risk. It's more than 8, then you combine it with other methods and you decide. Consider the EASL guidelines are not that keen on liver biopsy, so you can use that. What about Asia Pacific guidelines? I think, of course, Asia Pacific needs to be updated more. So a basic transient is a screening tool where available transient establish techniques recommended in initial assessment for significant liver fibrosis and cirrhosis. Transient electrodes helps to predict complication cirrhosis prognosis and the interpretation of results should be carefully made in the presence of Bagino 7 is not out feature. But there are few things I'm sure Professor Kaushal talk about that. This is the overlap. Yeah. The rule of 5 that means 10, 15, 20, 25. Those are and 5 of course. Those are the key values that should be so if you see how it decompresses. So below 5 is normal, there's no problem. Between 10 to 15, that can be a problem. So the compound comes in. 20, again, you can think of compensated advanced chronic liver disease. Another important term to remember, compensated advanced chronic liver disease. And more than 25, there's significant portal hypertension, and patients need to have upper GI. So this diagram I prefer more than the previous one. I modified it. So if you think of BMI more than 30, use the large probe. BMI less than 30, use the standard probe. And below 5, no problem. If it's below 10, unlikely to have compensated advanced liver disease. If it's between 10 and 15, that is gray area, and we have to investigate that. If it is more than 15, then you can expect advanced, considered advanced liver disease. Again, more than 20, then you are talking, do you need to do between 15 and 20, do you need to do endoscopy? That will, this is from readiness 7, that will depend on the platelet count. If the platelet count is below 110, then you consider endoscopy. If it's between 20 and less than 25, then the platelet count less than 150, you will again do endoscopy. And more than 25, you know that there is portal hypertension, so you will definitely do it. What about the CAP score? We know that ultrasound needs 30% of CAP to diagnose. So 5 to 10% is 1, 248. 33% is 268, and 66% 280. So 280 is the magic number. Again, all the studies done using CAP versus histology as a reference. CAP usage is still evolving. We need a lot of studies with this. Strong association with BMI and metabolic syndrome. It's not as well established as previous research. So, cutoff of 75 decibel initial use diagnosed steatosis according to ESA guidelines. But we realize is when we look at the guidelines, is that when it comes to cutoff, so very little clear signal there. An IQR of more than 40 associated with error. However, it is a useful tool which needs to be studied more. What about other fibro? Most of the studies have been done with FibroScan, but FibroTap equally effective in studies, and we need more and more instruments which are cheaper and more accessible and simpler. Because transient elastography is here to stay, and definitely machines around. So if you take most of the studies are done, but similar results, measurements obtained with FP and FS, the facts correlated. There was significant difference in the absolute values consistently and examination time, and the number of invalid measurements were observed. Either device can be used by the care personnel of different backgrounds when sufficiently trained. The key here is what you're using. You should be familiar and you should be trained on that. So to summarize, Chairman, ladies and gentlemen, transient elastography is a vital tool in management of NAFLD. A value of less than 8 kilopascals rules out significant fibrosis while more than 8 rules in significant fibrosis. Value of more than 15 rules in compensated advanced chronic liver disease, and a value of more than 25 rules in clinically significant portal hypertension. LSM not only detects the degree of fibrosis but also predicts portal hypertension, varices requiring treatment, cirrhotic complications, and potentially carcinoma. CAP1 is a useful tool in the diagnosis and management of NAFLD, however, and it needs more data. Thank you.
It's a very good talk about the transient elastography in screening and management of NAFLD. Thanks, Professor De Silva. And I understand that you finally prefer the Baveno 7 criteria for the TE in the clinical practice. So my question is, it easy for you, for doctors, hepatologists in Sri Lanka to perform TE at your clinic and manage stratify the patients with their electro stiffness measurement. So for example, if the liver stiffness measurement is over 15 kilopascal, the endoscopy will be ordered.
It will depend on the platelet count. On the platelet count, more than 25, we will definitely go ahead and do. But otherwise, it will depend on the platelet count as well. So if it's below 110 and it's above 15, yes, we will do endoscopy. And if it's above 20 but less than 25 and a platelet count less than 150, we go.
Oh, yeah, good. Professor Maiden, do you have a comment or question?
I think it was a wonderful talk, and I think it's very important in the current day and age that a hepatology practice must have an access to a fibroscan in the clinic. And I think he highlighted that point very well with the first case scenario he presented, because a lot of people come to us, and earlier these people would have been missed. So many of them have compensated ACLD as defined by Babino. So especially the diabetics. So the diabetics who've been having diabetes for long term, almost 20% of them, if you look carefully, will have advanced fibrosis, and about 10 to 12% will have undiagnosed cirrhosis. So these people would have presented to us only when they had decompensated. So now with the advent of TE and its availability in clinics, it's become very easy to diagnose these patients early. And in our setup also, we've been trying to sensitize our diabetologists, the endocrinologists, to understand this fact that many of their patients will be harboring advanced fibrosis and they need to be managed accordingly. So I think that point was highlighted by this case.
Yes. Okay. So I totally agree with both professors, because in my unit, every patient to visit our clinic to get the TE measurement. And generally, just like Professor De Silva and Professor Maiden, we stratify them with stiffness. And so unfortunately, many patients, they do not have the endoscopy, even the value above 20 or even 25 kilopascal. So I think we need to give more data about the TE in the ACLD in the cirrhosis management. And okay, the following question is that do both professors notice that for the obese patients, if the body weight decreased sharply and the liver stiffness measurement, the values also decreased accordingly. So that really means the liver fibrosis, how to say, the attenuated or reversed?
I think one of the absolute transient elastography reading, the LSM value, may in these patients also reflect some inflammation which might be going on in the liver. So the initial improvement may also be related to inflammation, which is coming down. So this was, I think, classically seen in the era of DAA use in hepatitis C. So you remember many of these patients, the LSM would be high. You start them on directly acting antivirals, their LFT, AST, ALT becomes normal, some values which they had never seen in their lives. And you do a fibroscan measurement after a month and you see that there is a significant decline. You were labeling these patients as cirrhotics or CACLD a month back, and 2 months down the line, the LSM is normal or in the F2 range. And that made you realize that possibly the inflammation in the liver also drives the LSM values. And yes, there is some data also to suggest that, especially in obese patients who have very high CAP or UAP values, there might be some overestimation of mild overestimation of LSM values due to high CAP.
Yeah, definitely agree with that. And the other issue is by doing fibroscan or transcranial, you have to use the obese patient BMI 30 or 28 to use a large probe, Excel probe, because that correlates better with the value. Then the other thing is, yes, definitely the information does correlate. And it's amazing how 10% weight loss, which is proven to reverse fibrosis, you can actually show that to the patient when he has a repeated transgenic done. So that, as Professor Kaushal mentioned, that is very satisfying the patient. One patient finally, when it's evidence-based, we know that 10% weight loss can reverse fibrosis in nothing.
Yes. Yes, I agree. Maybe at this scenario is the inflammation maybe more important than the fibrosis. Yes. Okay. And I'm sorry, all the question all from me. And my final question is that, is it possible for hepatologists to build or to establish same criteria for FibroScan and the FibroTouch to rule in ACLD or to rule out advanced fibrosis? Because maybe we have 2 machines, or even in the future 3 or 4 platforms. So for we are the customers. We need a very simple criteria for the different platforms. So it's an open question. Yes.
See, I've had the privilege of using both the machines extensively in my clinical practice, and my personal observation was that this particular machine, the FibroTouch, the one from High Sky, it has the advantage of having a single probe even for obese patients. So you don't have to spend more on the Excel probe. And the other high-end machine which they have, the FT1000, also has an inbuilt ultrasound platform which can be used for splenic stiffness. But having said that, in terms of its comparison to FibroScan, it sometimes give a value which is 1.5 to 2 times, 1.5 to 2 points, not times. So slightly higher than the original FibroScan machine. So if you know that, I mean, if you are the, like you said, the customer, you are the user base, if the hepatologist himself is doing the FibroScan, he knows about the case, then he's able to know that what these values mean. But if you get it done from, say, somewhere else, from a third vendor, a technician is doing it, and the patient comes back with a report, then I would say both machines you can have wrong interpretations of readings from both the machines. It's very important. I usually call transient elastography as a hepatologist stethoscope. So it should be available in your OPD. You should be able to do it. Then the interpretation is correct. Either machine you may use. And I agree with you, we need to have cutoffs for both the machine.
And Professor Arjuna?
Yes, I think that brought up a very valid point. So that the pathologist stethoscope, I think that's very, very important, that someone who can really interpret this and implement, treat, do everything, like the pathologist use the machine instead of third party, because then the problems will arise. But I'm sure, like with time, because transient elastography is here to stay, and it will become like the normal ultrasound in the future. So therefore, very soon, I think cutoffs will come, universal cutoffs will be there. we do more and more comparative studies. So I think what's important is to make this more and more accessible to people, especially so that we can use this to the maximum. So definitely that's the way to go forward. The person who uses it should understand the machine well and to be able to be comfortable with that and interpret it. That's the most important.
Yes, agree. And question from our audience for Professor Maiden, because Professor Maiden talked about the spleen stiffness in prediction the portal hypertension, and the audience confusion is that maybe sometimes the spleen size is some small and it's difficult to perform successful spleen stiffness measurement. So how about your experience about the spleen stiffness measurement in clinical practice, Professor Maiden?
Yeah, so I think you have to have a machine which has an inbuilt ultrasound probe to be easily able to do it. Otherwise, you'll have to have two machines, one the FibroScan or FibroTouch machine and a small portable ultrasound to localize the spleen at the area where the depth is at least 4 centimeter. Otherwise, both the companies have versions which have built-in ultrasound probes. The one I talked about from High Sky is the FT1000. I don't know whether I'm correctly pronouncing the name. And the other one from FibroScan is 630, their 630 version, which has a inbuilt ultrasound probe, which helps you do the splenic stiffness also. So that's the best way of doing it. No, right now we are not doing it routinely in our clinical practice, but I'm sure in future measurement of splenic stiffness after a patient has developed cirrhosis or CACLD is going to have many applications for these patients.
Yes. And also we have made the spleen stiffness from since 2019, because using the old version of the FibroScan, and sometimes the operator need some training, and the patients, the obese patients or ascitic patients, that will decrease the performance of the spleen stiffness measurement. And I know, and the FibroScan has a new machine for the dedicated spleen stiffness measurement. It's a new one, and I wish the FibroTouch will provide a new option for us. I understand that the FibroTouch one to measure the spleen stiffness is not the range, the values of the range is not so wide. So I agree with Professor Maiden that in the future the spleen stiffness measurement will be more important for clinicians to recognize, to manage the portal hypertension of our patients. Yes, I agree. So I will conclude this session. And first, I will thank the both excellent speakers and our audience, because the topic is very clinical useful for the hepatologist, because Professor Arjuna talked about the T in the NAFLD patients. That means it's a wide spectrum of disease. And Professor Menda talk about the T in the cirrhosis in ACLD and the portal hypertension. So it's it's a full spectrum of our disease. And the second is that the transient elastography is a very easily and friendly tool for operators, for hepatologists. Just like Professor Maiden mentioned, that the hepatologist perform the measurement and interpret the values and care the patients. So this simple machine will I mean, provide us a very useful tool. And finally, we will thank HSK Medical. Like I mentioned, this young and novel company from China has invested much in the non-invasive technology for liver disease, and their product, the FibroTouch, all over the world, from the One Silk One Road area, the Asian Pacific areas, and we wish more data, more academic activity from HSK Medical itself, or it sponsored the research studies. So, and finally, thanks our audience and our speakers, our sponsors. We wish to see face-to-face in the future. Okay.
Thank you.
Okay.
Thank
Thank you
you.
very
Thank
much.
you.
Bye.
Okay. See you.